Why don't we talk a little bit then about optimizing outcomes and using best practices? Because the efficacy of obesity and TDM drugs, T2DM, which is type 2 diabetes mellitus, is undetermined. And it's undermined to some degree by poor adherence. And we can determine that it's not good, but if you don't adhere, it's all just dug out, right? In clinical trials, on average, 30% to 50% of patients discontinued obesity drugs over the course of a year. And I think you alluded to that earlier. Adherence with type 2 diabetes mellitus drugs, less than 60%. And that's a life-threatening disease. Better adherence to therapy is associated with substantial cost savings, $5 billion in recent analyses through the reduced use of emergency departments, hospitalizations, so on. The SHIELD study found associations between weight loss and improved adherence with type 2 diabetes medications. Patients who lost weight were more likely to be adherent with type 2 diabetes mellitus medications. Even a 1% weight loss improved adherence. But greater percentage weight loss correlated with increasingly better adherence. All right, so far, not surprising. So I guess we have to ask the question, what do we know about long-term adherence? How do we push it? How do we make people want to adhere better?
Well, I guess I'd start with the patient, and I think a very powerful motivator is if we can support the patient, but also think about intrinsic motivators that are going to want the patient to do something for the long term. And they're seeing success. Perhaps if they're seeing the short-term success around some, even modest, weight loss, it's going to get them refocused on the whole lifestyle.
Yeah, that was my
exercise.
point back when you could just get 2 kilograms, 3
Absolutely.
kilograms. They're seeing something, right?
Absolutely.
So that helps.
But I think there's also support that needs to occur between the physician, the paraprofessionals, pharmacists, high touch, and the physician doesn't always have time for this. So how can we get, again, a very focused, patient-centered approach that deals with what patients need in terms of support, education, health literacy? And I think we're almost at the cusp when we think about health information technology. What can happen in the patient's home? How can we continue to deliver that degree of support the way the patient wants it and the language that they want? And very important for adolescents. Adolescents are incredibly difficult to get a hold of. When you call, they don't answer the phone, so the care management tools historically don't work very well. So
if you live with them, they don't answer you. I mean, come on. You expect them to pick up the phone?
So I think we have to think about what makes sense from, again, a support perspective, that some is going to be high touch, and pharmacists may play a very significant role in this effort. But the other is what other innovative tools really become very effective in the outreach and even an extension of what care management can look like.
If a doctor, on average, has about 7 minutes of FaceTime with a patient, that's not going to get this done, is it? So are we talking about physician extenders? Are we talking about lower cost options?
I think one of the things that our group has done is we've tried to stratify our population. So the patients that are highest risk of going to the hospital, we're trying to include some additional touch points in those patients. Another thing that we're doing is we have a pilot project where patients that have diabetes are getting a text message to remind them to take their blood sugars, and if they're above certain thresholds, then they call in and either talk to our diabetes educators or somebody at the office. So I think some of these other modes, maybe the 21st century methods that we can reach out to patients and maybe improve adherence.
Yeah, I agree. I mean, the patient can't do this by themselves. The provider cannot do this by themselves. Managed care is in a unique position because we have the data. So that's one of the challenges, but I do agree. I think this has to be patient-centric. So we've done a lot of things for patients, including waiving co-pays for drugs, all kinds of things, trying to improve compliance. We know that doesn't work. They have to be involved and they have to be motivated. And so we're in a unique position to do that. So some of what we're doing, and I think a key is risk stratification. So we can't do this for 20,000 diabetics, but we need to find the right patients. And then within that, it's looking at risk, it's looking at comorbidities, it's looking at these things, and then it's involving programs like pharmacist-centric MTM, integrated care management. So we've redesigned our care management that includes teams of pharmacists, nurses, and social workers working together on cases, because you mentioned depression earlier. There's a lot of other things that go into this. So we've kind of re-triggered that. But these types of models are, if we do get to the point of having ACOs and patient-centered medical homes, I mean, we have these out there right now, but if that becomes the standard, then the providers and other people are going to need help managing those types of models. And managed care is in a unique position to do that. But we have to change our processes.